Hi, my name is Dr. Jean Wong and I'm one of the obstetricians at OGCG. Today I thought we'd talk a little bit about stillbirth prevention. I think that it's a topic that many of you will be familiar with, but I thought it would be useful to go through all the information in one place and let you know a little bit about some of the newer initiatives that have come up in the last year or so. So just a little bit of background to start with. The definition of stillbirth is a baby born without any signs of life after 20 weeks gestation or weighing more than 400 grams. The incidence in Australia is 6.8 per 1,000 births, which roughly equates to about 2,000 stillbirths a year. The risk factors, I'm sure you're aware of, they centre around maternal risk factors such as advanced maternal age, drug and smoking use, Indigenous and Torres Strait Islander heritage, but also pregnancy factors such as abnormal fetal conditions, rhesus disease, as well as extreme postdates. In Australia, we've actually had very little improvement in our stillbirth rates over the last 20 years. One of our patients now, when pregnant, has a 35% chance more of having a stillbirth than women in the 6 best performing nations. They're typically Scandinavian countries and European nations. Just to show you visually, on the left-hand side of this slide, this represents the ARR, which is annual reduction rate, measured between 2000 and 2015. It's a little bit difficult to see, but Australia is about a third of the way up from the bottom. We've had an annual reduction rate of 1.4%. This is in comparison to countries such as the Netherlands, which has had a 6.8% reduction, and Belarus, which has had a 4.2% reduction. If you have a look at the right-hand side of the slide, that represents the number of stillbirths per 1,000 births. It is measured after 28 weeks gestation, which is typically where we would target most of our interventions. Australia is sitting at about 2.7 out of 1,000 births, but it's important to remember that this slide really just represents high-income countries and doesn't include third world nations or developing nations. Just to let you know a little bit about the Safer Baby Bundle, this is an initiative that's grown out of the work from the Perinatal Society of Australia and New Zealand, as well as the Stillbirth Centre of Clinical Research Excellence. It's an e-learning activity that's available for free. There are 6 modules. They take about 20 minutes each, and there's the all-important CME points at the end. But apart from e-learning, there's also clinical decision-making tools, algorithms, as well as clinical resources for you and your patients, as well as public awareness campaigns. It centres around 5 areas that we are aiming to target to reduce the risk of stillbirth, and they are smoking cessation, management of fetal growth restriction and reduced fetal movements, safer sleeping positions, and timing of birth. I'm just going to go through these 5 things really quickly, just to touch upon them. The first is smoking cessation. I'm sure most of you are very comfortable speaking to your patients about smoking. About 10% of women who are pregnant smoke in Australia. They're 1.4 times more likely to experience a stillbirth than their non-smoking counterparts. That's usually mediated through carbon monoxide, reducing the umbilical cord blood flow, reducing placental oxygenation, as well as abnormal placentation. So when we see our patients, we normally ask them about their smoking history, but also find out a little bit about passive smoking exposure. The Safer Baby Bundle recommends carbon monoxide level screening. I'm not entirely sure how many of your practices have a carbon monoxide monitor. We also advise them a little bit about the benefits of smoking cessation as well as resources available, and then help to refer them to the quit line and consider nicotine replacement therapy. Just bear in mind, pregnant women have a higher metabolic rate, so they may require a higher dose of nicotine replacement, and we would consider a minimum course of 12 weeks. There's currently no evidence to suggest the efficacy or safety of e-cigarettes, and smoking cessation drugs are not recommended. Moving on, we're looking at fetal growth restriction. That is usually secondary to placental dysfunction. The most important thing about fetal growth restriction is remembering that Small babies don't always mean fetally growth restricted babies. So a small for gestation baby is usually one that's under the 10th percentile, but in fact most of these babies actually aren't growth restricted, and lots of growth restricted babies actually weigh more than the 10th percentile. So in terms of how we manage this, we always screen for fetal growth restriction at every visit, starting from the first one. We're identifying risk factors, but we have to remember that more than 50% of growth restricted babies occur in mums who have no risk factors whatsoever. So normally I measure symphysial fundal height from 24 to 28 weeks, and then at every visit thereafter. If there has been slowing growth or static growth, or there is a large discrepancy between the symphysial fundal height and the dates, I would order an ultrasound. So it's important to remember though that women whose BMI is above 40 or women with large fibroids, sometimes the symphysial fundal height is difficult to measure. So with an ultrasound, the important thing to remember is that one single scan has the possibility of detecting up to 60% of growth restricted babies. That's compared to routine antenatal care, which often only picks up 2%. On scan, obviously we're looking at estimated fetal weight, but importantly I'm looking for head circumference and abdominal circumference. A large discrepancy between the two may suggest brain sparing. Also I look at amniotic fluid volume as well as umbilical artery Dopplers, which might show some resistance to flow. Just bear in mind that one scan does not assess growth velocity. So I think if you've got persisting clinical suspicion of a growth restricted baby, I would always repeat a growth scan at a 2-weekly interval. Here's my obligatory slide of very difficult to read words. This is from the Safer Baby bundle. It is available online. It stratifies women into low, moderate and high risk for growth restricted babies, and then it gives you a little bit of suggestions about what to do in terms of interventions such as low dose aspirin, when to start monitoring and the intervals of monitoring. Moving on to reduced fetal movements. This is a very important potential predictor of stillbirth, so it's a key strategy in our prevention. Usually reduced fetal movements are secondary to placental dysfunction, and that usually occurs as there is reduced fetal oxygenation and the baby then tends to move less in an effort to conserve energy. Just some important things about fetal movements. Normally I would speak to my patients about when they first start feeling movements. That's typically between 16 to 20 weeks. Most babies, all babies, will have sleep cycles. They'll often go up to 90 minutes of duration where the baby doesn't move at all. There is a wide variation though between all babies, and there's no universal definition of normal. The really important point to hone in with advice with your patients is that the fetal movements shouldn't reduce in strength or frequency as they get closer to their due date. And I think maternal concern is the most important thing in deciding when to intervene or when to investigate. The other thing that's worth thinking about is that kick counts or kick charts themselves aren't useful in reducing the risk of stillbirth. It's really just the increased vigilance or awareness of fetal movements that is vital in prevention. Here's another tiny algorithm. This is how you might approach a patient who presents to you with reduced fetal movements. Obviously when you first see them, take a clinical history and examination. We have a CTG in our office, so women who are above 28 weeks gestation, we usually invite in for a CTG. If the history and examination and CTG are reassuring, that's often enough. But I have a very low threshold to organise a growth ultrasound to exclude growth restriction. Especially if they haven't had one in the last 2 weeks. I think that's also provides reassurance for patients. I also consider a Kleihauer as well in case there are some potential signs or symptoms of fetal maternal hemorrhage. The last box on this algorithm refers to timing of birth, which becomes a little bit more important if the patients have persistent or recurrent reduced fetal movements and are close to their due dates. I think the next one is side sleeping. This is fairly self-explanatory. The supine going to sleep position has been shown to be an independent risk factor for stillbirth, increasing the risk by about 3.7%. This is mediated through reduced cardiac output, as well as reduced blood flow through the aorta and the IVC when the patient with a gravid uterus is lying supine. We've been able to see this on MRI studies. So I usually tell my patients it's very normal for them to change positions multiple times over the night when they're sleeping, but it's the first position that they go to sleep in that's maintained the longest, so that has the greatest impact on the fetus. We like them to start the night on their sides. Either side is safe, but if they wake up on their backs, it's not the end of the world. Just roll back onto their side and settle back to sleep. And finally, we look at timing of birth. This is often managed at the hospital or obstetrician level, but currently we have no evidence to support non-targeted induction to prevent stillbirth. And what we're really trying to do is achieve maximum maturity for the fetus whilst balancing the risks of remaining in utero. There are a couple of resources that might be helpful for you to speak to your patients about if they're asking about the rationale for induction. The first is the ARRIVE trial. This was published in the New England Journal of Medicine in 2018. It compared the outcomes of women who underwent either an induction compared to women who had expectant management in low-risk nulliparous patients. What it was able to show was that the induction arm patients had a lower chance of an emergency Caesar, as well as a trend towards improved perinatal outcome. So whilst not a study about stillbirth in itself, it's possibly something that can reassure patients about the safety of induction if required. Every Week Counts is something your patients can access themselves online. It's grown out of John Morris's work in New South Wales, and it really centres around a growing body of research that shows us that fetal brains are still maturing, they're still growing, and there's still myelination happening even between 37 weeks, which we traditionally consider term, right up to 40 weeks. So an early term delivery, one that happens between 37 weeks and 38 weeks and 6 days, compared to a late term delivery, which is 39 weeks onwards, confers some short as well as long-term risks. Typically they're things such as increased admissions to special care nursery, but more importantly, I think the longer term risk could well be some things like poorer school performance as well as neurodevelopmental delays. Just a really quick note about stillbirth and the Safer Baby Bundle in the time of COVID-19. There is no evidence at the moment to suggest that infection with COVID-19 increases your risk of stillbirth. However, stillbirth will obviously still occur. So our management, our monitoring, our interventions for prevention, they are unchanged. In fact, with smoking cessation, it seems even more important that we advise our patients to stop smoking in this time. There's also no evidence at the moment that if a patient is infected with COVID-19 that we induce labour unless for maternal grounds. So in summary, you can see that there are some very simple and straightforward modifications to care and the advice that we give our patients that have such a powerful effect in reducing their risk of stillbirth. And I think it's a really rare privilege for us to be able to offer that. Thanks for giving me this opportunity to speak about such an important topic. I hope it's been helpful. Thank you.